Fluid responsiveness is one of the most important concepts in modern critical care and perioperative medicine. For many years, clinicians relied on static measurements and isolated hemodynamic values to guide fluid administration. However, contemporary practice has shifted toward a dynamic, physiology-based approach. The central question is no longer whether a patient appears hypovolemic, but whether giving fluid will actually improve cardiac performance. Fluid responsiveness focuses on predicting whether a patient will increase stroke volume and cardiac output after a fluid challenge. This transition from static snapshots to dynamic bedside interventions has transformed fluid management, helping clinicians deliver fluids more precisely while reducing the risks associated with unnecessary fluid administration. Before administering intravenous fluids, clinicians must first identify evidence of inadequate tissue perfusion. Fluid therapy is a medical intervention and should only be given when signs of hypoperfusion are present. Common indicators include tachycardia, which reflects a compensatory response to reduced circulatory effectiveness, and hypotension, particularly a low mean arterial pressure. Oleuria, or decreased urine output, suggests impaired renal perfusion. Elevated serum lactate levels indicate tissue hypoxia and anaerobic metabolism, while poor capillary refill, mottling, or peripheral vasoconstriction reflect compromised microcirculatory blood flow. The presence of these findings raises concern for inadequate oxygen delivery and signals the need for further hemodynamic assessment before fluid resuscitation is initiated. The primary goal of fluid resuscitation is not simply to increase blood pressure. Instead, the objective is to improve cardiac performance by increasing preload, which subsequently increases stroke volume and ultimately enhances cardiac output. Fluids are beneficial only when they improve the heart's ability to pump blood effectively. If a fluid bolus fails to increase stroke volume, then it has failed to achieve its primary physiological purpose. In such cases, additional fluid administration may expose the patient to unnecessary risks without providing hemodynamic benefit. Therefore, every fluid The Frank-Starling curve provides the physiological basis for understanding fluid responsiveness. This relationship demonstrates how stroke volume changes in response to increasing preload, represented by ventricular end diastolic volume. Initially, as preload rises, myocardial fibers stretch and contract more forcefully, leading to a significant increase in stroke volume. However, this effect is not limitless. Beyond a certain point, the curve begins to plateau, indicating that further increases in preload produce little or no additional improvement in stroke volume. Understanding this relationship is fundamental because it explains why some patients benefit from fluid administration while others do not. The patient's position on the Frank-Starling curve ultimately determines their response to fluid therapy. Fluid responsiveness depends on where the patient lies on the Frank-Starling curve. Patients situated on the steep ascending portion of the curve are considered fluid responsive because a fluid bolus significantly increases stroke volume. In contrast, patients located on the flat plateau portion are fluid unresponsive, meaning additional fluid produces little or no increase in cardiac performance. Administering fluids to patients on the flat portion of the curve mainly increases hydrostatic pressure without improving circulation. This can result in pulmonary edema, tissue edema, and other complications associated with fluid overload. The goal of hemodynamic assessment is therefore to identify whether a patient remains within the window of responsiveness before administering additional fluids. Modern hemodynamic management has shifted away from static measurements toward dynamic assessments of cardiovascular function. Traditional static measurements such as central venous pressure, or CVP, and pulmonary artery occlusion pressure, or PAOP, provide only a single pressure value at a single moment in time. These measurements have been shown to be poor predictors of fluid responsiveness when used alone. Dynamic interventions, including pulse pressure variation, stroke volume variation, bedside echocardiography, and passive leg raising, evaluate how the cardiovascular system responds to a physiological challenge. By observing real-time changes in cardiac output or stroke volume, clinicians gain a much more accurate understanding of whether fluid administration is likely to be beneficial. Modern hemodynamic management has shifted away from static measurements toward dynamic assessments of cardiovascular function. Traditional static measurements such as central venous pressure, or CVP, and pulmonary artery occlusion pressure, or PAOP, provide only a single pressure value at a single moment in time. These measurements have been shown to be poor predictors of fluid responsiveness when used alone. Dynamic interventions, including pulse pressure variation, stroke volume variation, bedside echocardiography, and passive leg raising, evaluate how the cardiovascular system responds to a physiological challenge. By observing real-time changes in cardiac output or stroke volume, clinicians gain a much more accurate understanding of whether fluid administration is likely to be beneficial.
The limitation of static pressure measurements can be understood through the gas gauge analogy. A gas gauge tells us how much fuel is present in a vehicle, but it provides no information about whether the engine will actually start and perform effectively. Similarly, a specific CVP or PaOP value only indicates a pressure measurement and does not predict how the heart will respond to additional preload. Two patients with the same CVP value may have completely different cardiac outputs and occupy different positions on the Frank-Starling curve. Therefore, a single pressure measurement cannot accurately determine fluid responsiveness. This fundamental limitation explains why static measures have largely been replaced by dynamic assessments in modern critical care practice.
Dynamic assessment methods solve this problem by directly testing the cardiovascular system. Instead of measuring a static pressure value, clinicians create a small, reversible change in preload and observe the immediate effect on stroke volume or cardiac output. This approach is similar to testing an engine rather than simply checking the fuel gauge. The process involves inducing a temporary physiological challenge, measuring the real-time hemodynamic response, and determining whether cardiac output increases. If stroke volume rises significantly, the patient is likely positioned on the steep portion of the Frank-Starling curve and is considered fluid responsive. This strategy provides a more accurate and clinically relevant assessment of fluid requirements. Two important dynamic parameters obtained from arterial line monitoring are pulse pressure variation, or PPV, and stroke volume variation, or SVV. PPV measures the respiratory-induced variation in arterial pulse pressure during mechanical ventilation, while SVV evaluates breath-to-breath changes in estimated stroke volume using advanced hemodynamic algorithms such as FlowTrack. During positive pressure ventilation, changes in intrathoracic pressure affect venous return and cardiac output, creating predictable fluctuations in these measurements. A PPV or SVV greater than approximately 12 to 13% strongly suggests that the patient is fluid responsive and likely to benefit from fluid administration. These parameters have become valuable tools for guiding goal-directed fluid therapy in appropriately selected mechanically ventilated patients. Pulse pressure variation is based on the physiological interaction between the heart and the lungs during mechanical ventilation. During positive pressure inspiration, intrathoracic pressure increases and compresses the vena cava, reducing venous return to the right side of the heart. This temporarily decreases right ventricular preload and reduces the amount of blood entering the pulmonary circulation. After a short delay of a few heartbeats, this reduced volume reaches the left ventricle, resulting in a transient decrease in left ventricular stroke volume. Consequently, arterial pulse pressure falls. During expiration, venous return improves, stroke volume rises again, and pulse pressure increases. These cyclical respiratory changes form the physiological basis of pulse pressure variation and allow clinicians to assess fluid responsiveness in appropriately selected patients. Pulse pressure variation can be visualized directly on the arterial waveform. During a respiratory cycle, arterial pulse pressure fluctuates between a minimum value, called ppmin, and a maximum value, called ppmax. PPV is calculated using the formula. PPV equals the difference between ppmax and ppmin divided by the average pulse pressure, multiplied by 100. The larger the variation in pulse pressure during a single breath, the greater the respiratory influence on cardiac output. A large swing suggests that the heart is operating on the steep portion of the Frank-Starling curve and is therefore fluid responsive. Conversely, minimal variation indicates that additional preload is unlikely to produce a significant increase in stroke volume. For pulse pressure variation and stroke volume variation to provide reliable information, 4 strict physiological conditions must be met. First, the patient must be fully mechanically ventilated with no spontaneous breathing efforts, meaning the ventilator performs 100% of the work. Second, the tidal volume should exceed 8 milliliters per kilogram to generate a sufficient intrathoracic pressure change. Third, the patient must be in normal sinus rhythm because arrhythmias such as atrial fibrillation create irregular pulse pressures that invalidate the measurements. Finally, the chest must be closed with normal intrathoracic pressure dynamics intact. If any of these conditions are absent, PPV and SVV may become inaccurate and should not be used to guide fluid therapy. Bedside echocardiography provides a direct and highly informative method for assessing fluid responsiveness. One of the most valuable measurements is the velocity time integral, or VTI, obtained from the left ventricular outflow tract.
By measuring blood flow velocity through the LVOT before and after a fluid challenge, clinicians can calculate real-time changes in stroke volume. An increase in VTI reflects an increase in forward blood flow and cardiac output. Echocardiography therefore offers a dynamic assessment of cardiovascular performance, rather than relying on indirect pressure measurements. In addition, inferior vena cava variability can be assessed as a secondary tool, although its interpretation may be significantly influenced by spontaneous respiratory efforts and other physiological factors.
The passive leg raise, or PLR, is often considered the ultimate bedside test for fluid responsiveness. The concept is simple. Instead of administering an actual fluid bolus and risking fluid overload, the patient's own venous blood is used as a temporary and reversible preload challenge. By elevating the legs, blood stored in the lower extremities is shifted toward the central circulation and the heart. This creates a transient increase in preload similar to a fluid bolus. The major advantage of the passive leg raise is that its effects can be completely reversed simply by lowering the legs again. As a result, clinicians can safely evaluate fluid responsiveness without exposing patients to unnecessary fluid administration. The passive leg raise maneuver is performed in a systematic manner. Initially, the patient is placed in a semi-recumbent position, typically at 45 degrees, and baseline cardiac output is measured using echocardiography or an arterial line. Next, the head of the bed is lowered while the legs are simultaneously elevated to approximately 45 degrees. This position change causes a rapid transfer of venous blood from the lower limbs and splanchnic circulation toward the central circulation. The resulting fluid shift is equivalent to an endogenous fluid bolus of approximately 300 milliliters. Because the challenge is generated using the patient's own blood volume, it provides a reversible and physiologically safe method for assessing fluid responsiveness. After performing the passive leg raise maneuver, the physiological response must be measured accurately. Following leg elevation, clinicians should wait approximately 60 to 90 seconds to allow the maximum cardiovascular effect to develop. Real-time monitoring is then used to assess changes in cardiac performance. One option is measuring stroke volume using LVOT-VTI with echocardiography. Another option is evaluating pulse pressure changes using an arterial line. The key threshold is an increase in stroke volume or cardiac output of more than 10%. If this increase is observed, the patient is considered strongly fluid responsive, indicating that additional fluid administration is likely to improve cardiac output and tissue perfusion. Selecting the appropriate dynamic assessment depends on the patient's clinical condition. PPV and SVV utilize the mechanical squeeze generated by positive pressure ventilation and provide continuous automated beat-to-beat monitoring without requiring active intervention. Their major limitation is that they fail in patients who are breathing spontaneously, have significant arrhythmias, or receive low tidal volume ventilation. In contrast, the passive leg raise functions as an endogenous autobolus, using gravity to shift venous blood toward the central circulation. It performs well even in spontaneously breathing patients and those with severe cardiac arrhythmias. However, it requires active patient repositioning and real-time monitoring using echocardiography or arterial pressure measurements. A structured fluid management algorithm helps clinicians make rational decisions regarding fluid therapy. The process begins by identifying signs of hypoperfusion, such as tachycardia, hypotension, or elevated lactate levels. If these signs are absent, fluids should not be administered. If hypoperfusion is present, the next step is to determine whether the patient is fully intubated, passively ventilated, and in normal sinus rhythm. If these criteria are met, PPV or SVV can be assessed, with values greater than 13% suggesting fluid responsiveness. If the criteria are not met, a passive leg raise combined with echocardiographic VTI assessment should be performed. The clinician then interprets the dynamic response to determine the need for fluid administration. The final principle of fluid responsiveness is straightforward. If a dynamic test is negative, the patient is operating on the flat, unresponsive portion of the Frank-Starling curve. In this situation, additional fluid administration will not increase stroke volume and may instead contribute to pulmonary edema and tissue fluid overload. Therefore, fluids should not be given, and alternative therapies such as vasopressors or inotropes should be considered. Conversely, if a dynamic test is positive, the patient is functioning on the steep, responsive portion of the Frank-Starling curve. A carefully administered fluid bolus is appropriate, followed by reassessment of perfusion and hemodynamic response. The guiding philosophy is simple. Never guess what can be measured. Replace static snapshots with dynamic physiological testing to optimize patient outcomes and avoid unnecessary fluid administration.